The patient referral pathway acts as an immense, invisible filter across the healthcare system, concentrating the most complex pathology into specialized surgical hubs. Because of this funneling effect, the case mix inside a tertiary neurosurgical ward does not mirror general population disease incidence. It represents extreme selection bias. We can observe this dynamic clearly by examining a 2-year operational snapshot from NIMS University, a tertiary referral hospital in India. The total neurosurgical patient volume at the center consisted of exactly 279 consecutive admissions between June 2022 and June 2024. To understand how disease biology dictates clinical resources, we have to filter this entire volume down to a distinct subgroup. That isolates exactly 25 patients, representing 9% of the total admissions. This is the Neuro Oncology cohort. By tracking these 25 admissions from diagnosis through to discharge, we can clearly observe how the physical properties of a tumor, its exact location, and its biology align with early functional morbidity. This high-resolution view of a single center's case mix is what informs regional resource allocation. While global statistics provide the broad context, local snapshots like this are what define the specific requirements of perioperative planning and ward management. The clinical pathway splits immediately at the anatomical level, separating intracranial lesions from those located in the spinal compartment. 36% of this group, 9 patients, presented with spinal tumors. That high concentration is a direct artifact of the center's tertiary referral status, rather than a reflection of natural population incidence. Within those 2 broad anatomical compartments, the 25 admissions fall into 9 distinct diagnostic categories. This chart displays the specific distribution percentages across the entire cohort. Intracranial meningiomas are the most frequent diagnosis, comprising 24% of the group. They are followed closely by spinal intradural extramedullary tumors at 20% and intracranial gliomas at 16%. The long tail of the spectrum consists of lower frequency cases, schwannomas, extra and intramedullary spinal tumors, pituitary lesions, metastases, and a single ganglioglioma. A functioning tertiary service must possess the biological expertise and surgical infrastructure to handle routine benign extraaxial lesions, alongside highly complex, varied presentations across all central nervous system compartments simultaneously. The physical characteristics of these tumors are inextricably linked to the demographic realities of the patients who develop them. Even within this restricted sample, the age and sex distributions across the diagnostic categories align accurately with established global epidemiological markers. This stacked bar chart maps the gender divide across tumor types. On the top row, women account for 2/3 of intracranial meningioma admissions. By contrast, the bottom row shows male-dominated spinal cases, with both spinal intramedullary admissions being male. Shifting to age, the weighted average across the entire 25-patient cohort sits at approximately 39 years. However, that average masks extreme variations. Intracranial metastasis admissions skewed the oldest at 60 years, while spinal intramedullary cases skewed the youngest at 28 years. These predictable demographic clusters actively shape preoperative diagnostic pathways, informing everything from the specific imaging protocols required to anticipated perioperative cardiovascular risks. Moving past diagnosis and demographics, the cohort enters the clinical management phase. The treatment pathways in this study were categorized through a strict binary filter: conservative management versus surgical intervention. When the data splits, it reveals an overwhelming skew toward operative intervention. 84% of the cohort, 21 patients, passed directly into the surgical pipeline. 19 of those surgical procedures were complete excisions, while only 2 were restricted to biopsies. Certain pathologies dictated absolute responses. 100% of the meningioma, schwannoma, pituitary, ganglioglioma, and intracranial metastasis cases underwent excision. The remaining 16%, just 4 patients, were diverted to the conservative wing, receiving radiotherapy, chemotherapy, steroids, or active surveillance. These are pathways largely reserved for specific gliomas and spinal metastases. An 84% operative rate does not strictly reflect how these diseases are treated in the broader population. It perfectly illustrates the highly filtered, intervention-focused reality of a tertiary surgical referral hub. The final stage of this observational pathway evaluates the cohort's functional status at the exact moment of hospital discharge. Early morbidity is evaluated using 3 strict metrics: full recovery indicating a return to baseline, partial recovery indicating a residual deficit, and a severe outcome, analogous to a severe disability or vegetative state. There is a critical clinical caveat here. Inpatient mortality was explicitly excluded from the severe outcome category in the study design. This horizontal bar chart tracks macroscopic results for the entire cohort across 3 metrics. 56% achieved a full functional return to baseline. 28% were discharged with partial recovery. The critical morbidity rate sits at 16%, experiencing severe outcomes. A simple binary of alive versus dead sails to capture the true burden of neurosurgical disease. Discharge functional status serves as the most pragmatic, immediate measure of early operative and biological morbidity. Why did that specific 16% experience severe morbidity while over half the cohort recovered fully? The data correlates these severe outcomes directly back to the inherent anatomical and biological risks of their initial diagnoses. Tracing the severe outcomes backward through the dataset reveals a distinct pattern. The severe morbidity clustered almost exclusively in the highly infiltrative gliomas, the complex intracord spinal intramedullary tumors, and the single intracranial metastases. Conversely, full recoveries clustered densely around surface-level, benign extraaxial lesions like schwannomas and meningiomas, alongside spinal intradural extramedullary tumors. Infiltrative behavior and intracord spinal locations carry a vastly higher inherent operative risk than benign extraaxial tumors, heavily dictating discharge status. This dataset does have strict limitations. It is a small, retrospective sample that lacks tumor grade, molecular classification, extent of resection, and longitudinal progression-free survival data. The authors also note a modern publication standard. Artificial intelligence was utilized solely for language editing, ensuring the data generation, analysis, and clinical interpretation remained strictly human-driven. While a 25-patient observational cohort cannot demonstrate comparative treatment efficacy, meticulously mapping these admissions provides the exact baseline clinical data required to optimize local pathways and elevate the standard of regional neurosurgical care.